I think personalised imaging means we look at the precise tumour that you have and be able to know which tests are appropriate for you and which tests are not appropriate for you, because all tests have their good points, which is detecting something that's important, but they also have their bad points in what we call false positives, which is the test suggests there's something wrong and there isn't anything wrong. And all imaging tests have true positives where it's helpful and false positives where it's not helpful and causes harm, because we often end up doing a biopsy or another test. And what we've found out is that some tumour types, whether that's looking at the receptors on the tumour or whether it's how it looks down the microscope, are better imaged in one way and other tumour types are better imaged in another way. So rather than just doing, this is what we do for breast tumours, we do this, we do that, we do the other, we're much more precise now in saying, for this sort of tumour of this size, in a woman of this age, this is the imaging we should do before an operation and after an operation. It's like one of the things that people used to do was screen women to see if the cancer had spread to elsewhere in the body when they presented. And for most women, this is a complete waste of time because the percentage where that's happened is extremely low. But now we have much more precise information saying, if it's this sort of tumour, of this sort of age, of this sort of size, a CT scan's a good idea, but in this woman with this size tumour, this type of cancer, it's a bad idea. And so we're trying to use imaging that's going to end up giving us more useful answers and try and avoid the majority of the harms that can come from actually imaging too much. I mean, people think the more tests the better, but it's not true. Tests can end up doing you harm as well as good, and we have to make sure that we tailor the tests we do to the precise needs of that particular patient and their particular tumour.